This is Richmond upon Thames in 2026. It is an affluent, highly desirable slice of Greater London and the epicenter of a systemic crisis in human welfare. Demographers treat this borough as a time machine. Because of its specific population dynamics, Richmond is experiencing the acute pressures of an aging urban population years ahead of the national curve. While the median age sits at 41, the fastest-growing sector of the population over the next decade is the 80-plus age group. This is the demographic that requires the highest volume of physical and medical care. Meeting that demand requires a massive influx of social workers, nurses, and physical therapists. But those workers face a harsh opposing force: the local cost of living. This graph illustrates the mathematical friction at play. The projected growth of the 80-plus demographic intersects with a 5.7% annual surge in local rents, pushing average monthly costs to £2,276. Notice the widening gap between care demand and housing costs. The math is unforgiving. A workforce large enough to support this aging population cannot afford to live where they are needed most. Traditional legacy healthcare models, which rely entirely on physical proximity and manual human administration, are rendered statistically impossible here. This is the Richmond paradox. The people who desperately need daily care are isolated in neighborhoods that their caregivers cannot afford to enter. With average house prices holding near £795,000, nurses, social workers, and personal care assistants are permanently priced out of the local market. The borough's response has been to expand extra care housing. The strategy keeps the elderly living independently in their own homes, equipped with flexible on-site support services, rather than moving them into dedicated residential facilities. But if extra care relies on human administration to manage logistics, scheduling, and remote monitoring, it fails. It simply takes the existing labor shortage and spreads it across a highly decentralized map of individual homes. Bridging that gap requires the Mpelembe Network. It operates as a localized, digital collaborative platform that uses multi-agent artificial intelligence to orchestrate care relationships. High-density, high-cost urban areas can no longer solve social isolation with physical presence alone. Human welfare has to be architected as a complete digital ecosystem. Managing decentralized human welfare requires a foundation that never fails. You need a highly resilient, zero-latency digital pipeline to process immense volumes of sensitive health and social data. Developer Sam Mbale designed this architecture using the logic of mining and heavy civil engineering. His experience with major infrastructure shaped the platform's focus on structural reliability and high-volume resource flow. Mbale previously worked as a site engineer on the Thames Water London Ring Main, a massive subterranean tunnel built to guarantee water security. That physical logic translates directly to the digital architecture of the Mpelembe Network. Instead of concrete and water, this pipeline is built natively on Google Cloud. It is designed to orchestrate the flow of healthcare data and community support services with the same reliability as a public utility. This 3D blueprint shows the base layer. Cloud scalability manages massive traffic spikes, ensuring data from thousands of extra care homes connects without latency. This continuous connection tracks health outcomes and alerts off-site professionals to anomalies before emergency care is needed. In the Agentic Era, robust cloud infrastructure is a mandatory public utility. Without it, advanced AI cannot deploy to the edge of the network to do the actual work. A perfect cloud pipeline delivers the data, but human care hours are still restricted by the economics of Richmond. Software alone does not generate more nurses. The solution is the second layer of the network, CuraFlow AI, a specialized multi-agent intelligence system. Legacy healthcare IT operates on an autopilot model, acting as a static database that requires constant human data entry. CuraFlow introduces a co-pilot framework, where AI and human practitioners operate in a tight, active feedback loop. This diagram illustrates the second layer, CuraFlow AI. A multi-agent system divides clinical administration into discrete tasks. When data enters, agents execute simultaneously. The first processes intake paperwork, the second conducts remote clinical triage, and a third verifies the care plan against local health protocols. Workflows that historically consumed hours of a human practitioner's shift are completed in milliseconds. CuraFlow AI does not replace the caregiver. It automates the administrative overhead that can consume nearly a third of a clinical shift. By reclaiming those hours, the system maximizes the impact of the limited human workforce currently able to work within the borough. Clinical AI ensures medical stability, but it cannot cure objective social isolation. A healthy pulse rate means nothing if the patient lacks daily, meaningful human interaction. To solve this, the network deploys its final layer, an AI matchmaking system that recruits localized community volunteers to supplement professional care. Getting volunteers is easy, keeping them is difficult. To prevent compassion fatigue, the matchmaking algorithm is explicitly designed to trigger a biological response known as the helper's high. This visualization models the final layer, human chemistry. Engaging in altruism targets the brain's reward circuits, releasing specific neurochemicals. Dopamine links volunteering to pleasure centers, reinforcing motivation, while oxytocin fosters empathy and reduces the acute anxiety of isolation. This fulfills the core requirements of self-determination theory. The algorithm gives the volunteer the autonomy to choose, the competence of mastering a specific task, and the relatedness of a genuine connection. Repeated exposure to this neurochemical loop builds what psychologists call a volunteer role identity. The act of service transitions from a weekend hobby into a central pillar of the user's self-concept. By treating pro-social neurobiology as an engineered system, the platform converts transient, well-meaning neighbors into a self-sustaining, lifelong human safety net. This diagram reveals the three-tiered architectural stack. Google Cloud ensures scale, CuraFlow AI automates clinical administration, and the matchmaking layer engineers human connection. That £2,276 monthly rent barrier still exists, but inside this architecture, the economic constraint is absorbed by pure operational efficiency. Digital platforms are transitioning into active participants in the management of society. This network moves beyond hosting static content, assuming the role of a dynamic orchestrator for clinical and social welfare. The merging of global cloud scalability with high-fidelity multi-agent intelligence solves the Richmond paradox. It connects the isolated elderly with the exact professionals and neighbors they need, precisely when they need them. What begins as a localized solution for one wealthy London borough serves as the precise blueprint for navigating macroeconomic pressures facing aging urban centers worldwide. In the 2026 Agentic Era, successful healthcare architecture demands a wider view. Software, clinical workflows, and human neurobiology must be treated as equally vital components of modern civil infrastructure.